My topic for today is perioperative hypoxia, sir.
Hypoxia. Okay.
So, hypoxia definition, it is defined as a condition where the arterial oxygen tension is below normal. Normal PaO2 is 80 to 100 millimeter of mercury. It is also defined as failure of oxygenation at tissue level. There are 4 types of tissue hypoxia. Hypoxic hypoxia, where the PaO2 is insufficient, PaO2 is less, there is insufficient oxygen reaching the blood. Next is stagnant hypoxia. The cardiac output is less and increased shunting. So because of this, there is decreased blood flow to the tissues. In anemic hypoxia, because of decreased hemoglobin carrying capacity. And in histotoxic hypoxia, it is the inability of the tissue to utilize the oxygen. Coming to perioperative period, this includes the preoperative, intraoperative, and postoperative. First, we'll see the preoperative causes for hypoxia. Any pre-existing cardiopulmonary disease where there is decreased respiratory and circulatory compliances. Next is trauma. Any atelectasis and shunting imposed by the immobilization and the pain medication can result in hypoxia. Old age itself, because of decreased chest compliance, can cause hypoxia. Obesity, because of decreased and any drugs administered to the patient. So these are the causes for possible causes for preoperative hypoxia. Next, coming to the intraoperative hypoxia, it is divided into two: the problems with oxygen delivery system and problems with the patient. Problems with oxygen delivery system, it can be from at the level of central oxygen supply, at the level of pipeline distributing system, at the level of oxygen cylinders attached to the anesthesia machine, any problem at the level of anesthesia machine, at the level of ventilator and anesthesia circuit, and at the level of endotracheal tube. Problems with the patient is hypoventilation. If the patient is spontaneously breathing, it can be due to the effect of sedatives or narcotics, or in ventilated patient due to inadequate IPPV, it can result in hypoxia. Next is decreased FRC. Induction of anesthesia itself decreases the functional residual capacity by 15 to 20%, and the decrease is more in case of obese patients. Application of PEEP may compensate the decrease in functional residual capacity. Next is increase in airway resistance can result in hypoxia. Airway resistance can either be due to decrease in FRC, decrease in caliber of airways, because the ET tube itself, it decreases the size of the trachea by 30 to 50%. Anesthesia apparatus can cause the resistance. Any obstruction in the ET tube like secretion, kinking, and cuff herniation. And last is bronchospasm. Next is atelectasis. Atelectasis is a condition of alveolar collapse. It causes VQ mismatch, which results in right to left shunting, and this results in arterial hypoxemia. The conditions causing can be any surgical position or compression by wedges or any pressure. In this atelectasis, PEEP may be useful. Next, coming to absorption atelectasis, when FiO2 is very high, the alveolar O2, the PaO2 increases. The rate at which the oxygen moves from alveoli to capillary bed increases when there is high FiO2. So when the absorption rate is more than the inspired flow of gases, the lung unit collapses. So this is the reason for absorption atelectasis. Next, diffusion hypoxia. This is usually seen at the end of general anesthesia when nitrous oxide oxygen is switched off and the patient is allowed to breathe. The nitrous oxide is 31 times more soluble than the nitrogen. For every 1 molecule of nitrogen entering into the blood from the alveoli, 31 molecules of nitrous oxide enters into the alveoli from the blood. So there is dilution of the alveolar oxygen, and this results in hypoxemia. The treatment for this is 100% oxygen. This diffusion of hypoxemia is usually common during the first 5 to 10 minutes of recovery. Um, Inhibition of hypoxic pulmonary vasoconstriction. Inhibition of hypoxic pulmonary vasoconstriction can also result in hypoxemia. When the alveolar O2 decreases to one region of the lung, uh, there occurs vasoconstriction of that region. The blood flow is diverted to normal lung regions. So this results in decrease in VQ mismatch, and uh, no, PaO2 is maintained. This hypoxipulmonary vasoconstriction is a protective phenomenon. This inhibition of HPV, which is usually seen with inhalation of anesthetics, vasodilators like NTG and sodium nitroprusside, hypocapnia, hypothermia, and thromboembolism can result in hypoxemia. And generally, intraoperatively, when there is an oxygen, there is poor delivery of the tissues. The most common cause will be hypovolemia or systemic hypoperfusion can cause hypoxemia, or increase in oxygen demand, which is seen in conditions such as malignant hyperpyrexia, shivering, and sepsis can result in hypoxemia. Post-operative complication. Hypoxemia is common in post-anesthesia care unit. The factors can be airway obstruction due to continued sedation from the residual anesthetics or opioids. Reduced FRC and impaired oxygenation is usually normal within few hours after surgery. Atelectasis is also a contributing factor, especially after major surgery under GA. And last but not the least, residual neuromuscular blockade activity after GA. It is defined as UF less than 0.9, which is associated significantly lower values of forced vital capacity and peak expiratory flow rate. Assessment of oxygen is the most common is we use pulse oximeter. Others are FiO2 monitor and ABG. Next, there is a flow chart for management of hypoxemia. Algorithm. When the SpO2 is less than 94%, assume hypoxia until proven otherwise. In that condition, administer high flow of oxygen. Consider hand ventilation with large tidal volume. Check the probe on the patient. Check for the good waveform. If no, reposition the probe. If yes, check whether there is a patient problem or whether there is an equipment problem. In patient problem, go with the order A, B, C, D, E. A is airway, use chin lift or jaw thrust if mask ventilation. If LMA, reposition the LMA. If the tracheal tube, check the position of the tracheal tube. Auscultate both the lungs. Treat the laryngospasm if present. Next, B is breathing. Check adequate rate, adequate tidal volume. Check the EtCO2. Again, auscultate the lungs. Bronchospasm, bronchodilators can be used. If pneumothorax, consider a chest drain. Next, for circulation, we check the pulse, BP, ECG. Any blood loss or fluid loss should be assessed, and adequate IV fluid replacement. In equipment problems, check the oxygen supply, the concentrator or the cylinder. Check circuit disconnection or check any circuit obstruction. And drug effects can be due to opioids, sedatives, muscle relaxants, or high spinal. That's it, sir.
Very good. Very good. So, the basic thing, this question, if this is a question which has been repeatedly asked, perioperative hypoxemia. So you have to first classify into preoperatively existing hypoxemia, which may get exacerbated, or intraoperative hypoxemia, which is occurring during the procedure, and postoperative hypoxemia, which is very common due to the various causes she mentioned. So first classify like that. Before that, you define what is hypoxia. And as she rightly said, there are 4 types of hypoxia, all of you know, anoxic, hypoxic, stagnant, and all those things. And then you not only mention the causes, but then and there you give the corrective methods also. So just because the question says describe the causes of perioperative hypoxemia, it doesn't mean that you should mention only the causes. It is better to mention the remedies also then and there, so that the examiners will know that you have an idea about how to manage this hypoxia if it happens during a procedure. So I will just share PPT, which may give you a visual impression of what Sanjutha nicely described so far, and so that it is easy for you to remember. Are you able to see the slides?
Yes, sir.
So you can, I have put a heading here as causes and treatment of perioperative hypoxemia. So even if the question says describe the various causes of perioperative hypoxemia, don't just stop with the causes alone, but mention the treatment also. So first, the definition of hypoxia is reduction in oxygen in the tissues, and that may be because of the 4 reasons commonly known: hypoxic hypoxia, anemic hypoxia, stagnant, and histotoxic. And it can be classified as pre, intra, and post-op. And the pre-op causes pre-existing cardiopulmonary diseases. Patients who have already an existing cardiopulmonary diseases may come to you for surgery with an existing hypoxemia. So most important factors which may be they may have some respiratory complications like chronic bronchitis or COPD, where they have an inherent low saturation and low oxygen levels even before the surgery is happening, and already a low PaO2 or decreased respiratory or circulatory compensations which have taken place. Second important preoperative cause is trauma. Patients with acute hypoxemia, they are mostly encountered in polytrauma patients, and which may involve the ventilatory or circulatory systems. And some of them may result in, say, something like pneumothorax or a collapse of aspiration collapse, shunting by hemophilization, restrictive infusion, pain medication. So all these things are the pre-op causes of hypoxemia which may be existing, or it may be because of old age. As patients become older, their PaO2 gets decreased, and the formula that is used to accept PaO2 as normal is 106 minus the age of the patient by 2, or half the patient's age. For example, if a patient is 80 years old, 106 minus 80 by 2 is 40. So up to 66, he may be behaving normally without any problem. So it is not the saturation, it is the arterial oxygen tension. It gets gradually decreased. And that is the reason why in elderly patients, you cannot allow them to become too hypoxemic. So you have to take care of that, even though their PaO2 values will be accepted as normal by this formula. And after the age of 60, it ranges from 70 to 80 millimeter, and reduced compensation with which will cause an increase in cardiac output. And there may be reduced ventilatory response to hypoxia in elderly patients. So old age patients are always risky patients who can become hypoxemic very easily. So geriatric cases you have to handle very carefully and look for pre-existing hypoxic causes. Similarly, obesity. All of you know that obesity causes a restrictive pattern of lung disease, because of the fat deposition in the chest wall, which we discussed during our discussion on obesity. So these patients also may have pre-existing hypoxemia. Similarly, patients who are severely anemic, which may be, of course, chronic anemia, there are a lot of compensatory changes that are taking place, but in acute anemia, as in trauma, patients may have a reducing oxygen capacity, carrying capacity, which may cause them to become hypoxemic easily. And the restriction of respiratory motion by abdominal binders or other tight dressings that are especially in burns patient, it may be caused by the SR that is formed within after the burns of the chest and abdominal wall. You may find that there is a thick SR that is forming, which may restrict the respiratory mobility, and that may also cause the hypoventilation, leading to hypoxemia. Now coming to the intraoperative causes. So these are the points that you have to remember and write for the preoperative causes. Intraoperatively, it can be classified into, as we said, problem with oxygen delivery to the patient or patient's problem. These are the two categories due to which intraoperative hypoxemia can happen. And so decreased FiO2 is the main reason, either because of improper delivery from the machine or absence of proper oxygen supply to the machine. Of course, nowadays we have a lot of safety measures incorporated in anesthesia machine to prevent a hypoxia being delivered, which I think will be discussed by the next speaker. And alveolar PaO2 may be decreased, and oxygen tension in the arterial blood can get decreased oxygen content because of other contamination or the patient's own anemia, decreased cardiac output, and increased tissue metabolism. All this will lead to the patient problem. Whereas the delivery system at the level of central oxygen supplies, there may be low supply from the pipeline, or the cylinders might have got exhausted, especially in rural setup where you don't have, or a smaller hospital or a nursing home where there is no central pipeline supply. You have to be very watchful whether the cylinders, especially the spare cylinder that you have in your machine, you must always check whether it is either half full or more than half full before starting the case, so that the one you are using, if it gets exhausted during the procedure, must always have a backup cylinder which can be opened in cases where there is no central pipeline supply. And the ventilator pressure reducing valves may be faulty sometimes, or there may be a fault in the flow meter where there may be a crack in the flow meter, or it may be at the level of the anesthesia ventilators where there may be a leak, or circuit may be faulty, or endotracheal tube. So these are all mostly mechanical causes of decreased oxygen delivery supply. And of course, patient problem, it may be because of hypoventilation, reduced FRC, increased airway resistance, atelectasis, diffusion of hypoxia, shunt, and poor oxygen delivery to tissues because of hypovolemia or hypotension. And supposing patient develops malignant hypothermia, there will be increase in oxygen demand, or intraoperative sepsis causing a rise in temperature. All these conditions will increase the oxygen demand. So these are the problems with the patient. Now, patients at risk of hypoxia, especially preoperatively, they are smokers and COPD patients who have a reduced FRC. And of course, this is a repetition of what we saw in the preoperative causes, and surgical pathology, and hypothermia or fluid overload. So this is a flow chart which you can think of drawing in your answer. Mechanisms of hypoxia: lack of alveolar ventilation, lack of alveolar perfusion, decreased alveolar diffusion. And the lack of alveolar ventilation may be because of upper airway obstruction, respiratory depression, pneumothorax or bronchospasm, and atelectasis. So these are the causes of lack of alveolar ventilation. And pulmonary embolism is a condition where there is no pulmonary circulation, resulting in hypoxemia. And diffusion problem happens in pneumonia, ARDS, or pulmonary edema. So this picture will be easy to draw for you to explain the various causes at the lung level for the mechanisms of hypoxia. And each and every situation where you have given all these points, you can say what are all the remedial measures as you have said about it. Now, yesterday I happened to receive a article from the World Federation of Society of Anesthesiologists, WFSA, where they have given an article on called what is a physiologically difficult airway. Have you all heard of this terminology?
Yes, sir.
Sanjutha, what is
Yes,
that?
sir. Yes.
What is that physiologically difficult airway? We have known about anatomy.
Patient is at high risk of hypoxia, hypotension, metabolic acidosis, and right ventricular failure, sir.
So it is a difficult airway because of non-anatomical causes. Okay, when you say physiologically difficult airway, it is due to some pathology in the physiology of patient and not because of the anatomy of the patient. Okay, so I thought I will just give you a small hint because it is being a recent article. I thought it may appear in your question papers. So I just prepared this. Patient at risk of peritracheal intubation hypoxemia or hemodynamic collapse can be thought of having a physiologically difficult airway, where despite reassuring airway, that is an airway which can be easily intubated, but despite the fact that you are able to easily intubate and achieve a control over the airway, still if the patient becomes hypoxemic, then they call this as a physiologically difficult airway because of ongoing physiological death. So what are the peritracheal intubation recommendations for hypoxemic patients? So this is the recommendation how you try to control or treat this hypoxemia. First thing they advocate is pre-oxygenation. All of you know that we do pre-oxygenation for all the patients before starting general anesthesia as a protective measure to prolong the apneic oxygenation time. So here the high flow nasal oxygen peri-intubation hypoxia rates have been found to be quite reduced by this. Or you can do non-invasive positive pressure ventilation. In cases where there is a increase in the hypoxic pulmonary vasoconstriction, you can use pulmonary vasodilators like nitric oxide, and also you can use to improve the ventilation perfusion, the role of pre-oxygenation optimization. The second thing nowadays, all of you know there is a terminology called apneic oxygenation, which uses a standard nasal cannula or a high flow nasal cannula with 40 to 70 liters of oxygen per minute. And these two things, how the mechanism, apneic oxygenation by itself is a short note question. So how when the patient is not breathing or having any respiratory attempts, how oxygenation can be maintained is the main thing which is called apneic oxygenation. Patient is not breathing, but he doesn't become desaturated or hypoxemic because of the large volume of oxygen that is supplied to the patient, which replaces the anatomical dead space and becomes entirely covered with oxygen, just like increasing your FRC by your pre-oxygenation. Here, in addition to improving the FRC, we are eliminating the dead space volume also and replace it with 100% oxygen. And because there is a constant uptake of oxygen because of the pulmonary circulation, there is a negative pressure created, which will cause the movement of the oxygen that is available in the upper airway towards the alveoli, and that will keep on going for the patient. without interrupting with the oxygenation of the patient. This is the simple way of understanding this apneic oxygenation. And sometimes patient may have refractory hypoxemia because of the inherent conditions where you have to consider awake or a spontaneously breathing patient. So especially the index that is indicated for refractory failure is the PaO2 to FiO2 ratio less than 100. And other optimizations like point of sound ultrasound, and to identify the etiology, diagnosis of treatable conditions like pneumothorax, pulmonary edema, pleural effusion, pulmonary embolism, cardiac dysfunction, etc. And what are the methods of achieving optimal pre-oxygenation prior to tracheal intubation in a physiologically difficult airway? For this, you have to have first an effective seal of the face mask that you use and use a flush flow rate of 50 to 70 liters per minute. Then in case of ineffective seal, supposing a pedunculous patient or a patient with a facial trauma where you are not able to have an effective seal of the face mask, then what you do is you add a nasal cannula and then hold the mask also. Through the nasal cannula, you continuously supply 10 liters of oxygen per minute. That will increase that. See, here is an example. Of course, this patient is just given as a example for you to understand. You can see he has a nasal prongs or a nasal cannula already fixed in position. Over that, he has got a transparent non-rebreathing mask with a reservoir. So if you supply oxygen through both, then you can maintain, even if the mask is not fitting and there are a lot of leaks, this will be able to take care of the oxygenation. So a non-rebreather mask applied in combination with the nasal cannula will provide high minute volumes, and the pre-oxygenation in the head-up position to 20 to 30 degrees will increase FRC, thus minimizing the effectiveness of pre-oxygenation and prolonging the time for desaturation. So this intervention you must do carefully, because in hypovolemic patients or hypotensive patients, giving a head-up tilt may be disastrous because that will affect the cerebral circulation. So in a patient who is hemodynamically stable, you can safely give a head-up tilt of 20 to 30 degrees. And pre-oxygenation with NIP, non-invasive positive pressure ventilation, is also recommended with patients who have a shunt physiology, like as Sanjutha said with atelectatic patients. And high flow nasal oxygen has been shown to be quite equal to NIPPV. And patients with oxyhemoglobin saturation of less than 95%, who are not responding to the above techniques, are likely to improve with non-invasive positive pressure using either a mechanical ventilator or a manually assisted bag valve mask using PEEP of 5 to 10 centimeters. So three options are there for you for improving the pre-oxygenation. One is head-up tilt, second is NIPPV with the HFNO, and third is PEEP. So if you apply these three things, you will be able to adequately pre-oxygenate and improve the oxygenation in a physiologically difficult airway. And the inhaled pulmonary vasodilators can be used to improve oxygenation. Then how is hypoxemia graded by the ratio of arterial oxygen partial pressure to the fraction, that is PaO2 by FiO2, and what is its significance? So when you do back mask ventilation or using high flow nasal oxygen, you always, what should be the normal PaO2 to FiO2 ratio? How much should be the arterial oxygen tension when in relationship to FiO2?
More than 300.
That is, normally we are breathing room air, which has only 20% oxygen, but our arterial oxygen tension is roughly around 95 to 100. Almost 5 times we are having the ratio. Even if you don't have that 5 times ratio, you should have at least 3 to 4 times ratio. Okay, so 300 to 400 is considered as normal PaO2 to FiO2 ratio. So if the baseline PaO2 to FiO2 is 300 to 200, you give NIPPV, or depending upon the other things, you go on for finally, if the PaO2, FaO2 is less than 100, then you go for awake intubation, not using any sedatives or relaxants to further worsen the hypoxemia. Now, this short note question, apneic oxygenation is the application of supplemental oxygen without variable positive pressure. That is very important. It just flows into the upper airway through the nasal cavity and replaces all the anatomical dead space air by oxygen. So you don't apply any positive pressure here. Typically, it is supplied only by a nasal cannula in an apneic patient. And how does it work? The amount of gas tension is achieved via dead space flushing and turbulent gaseous mixing. This is the mechanism. What are the recommendations for correction of hypotension in patients undergoing tracheal intubation? So, the common methods are, as all of you know, whenever a patient is hypotensive, we first try volume administration. Then, if it is not responding, you go for vasopressors and inotropic support. Then you choose the correct induction agent. If you have to sedate the patient and then intubate, you choose the correct intubation agent. Propofol usually is independently associated with hemodynamic instability. It will always cause a little bit of hypotension, but mixing it with ketamine in situations where the hypotensive effect of propofol can be counteracted is always recommended. And you can do a assessment of the hemodynamic status by point of care ultrasound. What is the point of care ultrasound test you can find out to find out hypovolemia?
IVC diameter.
IVC compressibility. Excellent,
Collapsibility.
excellent. Very good. IVC collapsibility. Right. So why patients with metabolic acidosis are more prone for cardiac arrest during tracheal intubation?
During
Can you answer
metabolic
this question?
acidosis, increase in the potassium level because of cell deaths.
Oxygen demand is already more in the tissues, sir. So
Okay.
they easily go for hypoxemia when the demand is more, and
Okay.
the demand is more than the supply, sir.
Okay. What is the compensatory response of the body for metabolic acidosis?
Respiratory alkalosis.
It will be hyperventilation. The patient hyperventilate to wash out the carbon dioxide to get back the pH to normal. Okay. So even a temporary cessation of breathing, when you want to intubate a metabolic acidosis patient who is already hyperventilating, if you sedate, paralyze, and then try to intubate and take your time, you will aggravate the hypercarbia. Okay? So what happens? The patient is metabolic acidosis often hyperventilate in an effort to normalize their pH. Hence, even a brief apneic period can cause carbon dioxide to accumulate, further lowering the pH, thereby producing or triggering a cardiac arrest. Okay, that is the mechanism. So, further worsening of acidosis will happen because of CO2 accumulation. So, what are the peritracheal intubation recommendations for acidemic patients? These are the things. Delay intubation as much as possible by trying to correct the metabolic acidosis wherever the reason for metabolic acidosis is identified. Or you can go for non-invasive positive pressure ventilation, which improves pre-oxygenation and peri-intubation gas exchange. Or straight away go for awake intubation under topical anesthesia without any paralysis or sedation. And apneic oxygenation may provide unpredictable amount of gas exchange during apneic period. So that is still not a recommended thing. And peri-intubation bicarb boluses, that is a subject of debate. Correct the acidosis. Mention other conditions causing physiologically difficult airways. One is RV failure. So hypotension secondary to induction agent and increased thoracic pressure from mechanical ventilation can lead to reduced venous return and RV preload. Hypoxia, hypercarbia, increased sympathetic tone, and TA-induced increased intrathoracic pressure can lead to RV afterload. So it can affect both the preload as well as afterload. And patients with right ventricular failure warrant focused evaluation, careful fluid management, and consideration of inhaled pulmonary vasoconstrictor, dilators, and the intubation strategies, whether to go for awake intubation, and should be chosen to avoid hypoxemia, hypercapnia, acidosis, sympathetic stimulation, and hemodynamic instability. So RV failure, as Vidya said, it's one of the causes of physiologically difficult airway. The next is cardiac tamponade, which results in elevated LV filling pressures, impairing diastolic filling, resulting in fixed stroke volume and thus rate-dependent cardiac output, which may deteriorate further the preload
Dune
and
Part
systemic
2 for the
vascular
spectacle
effusion.
that I witnessed last night on IMAX. No joke, this movie and its
Aortic
execution
stenosis,
big screen
patient with
experiences
severe.
I had as a kid with Lord of the Rings, The Two Towers,
Hello?
or even the re-release of Empire Strikes Back. This is a rarity at a time where big production companies are mostly focusing on quantity over
Hello.
quality, and more importantly, where
Actually, I
there is
think some disturbance
creators
is
like
there.
Denis Villeneuve, who is loyal to the source material that not only has a huge fan base, but is very difficult to adapt for the big screen experience. Frank Herbert's Dune is no joke, and while David Lynch attempted the adaptation in 1984, it
Kamachi,
was not a production hell, transforming into a guilty pleasure for audiences more than
can
anything
somebody
else.
message Dr. Kamachi? There's some interference
Yes,
here.
sir.
Mother Lady Jessica, assimilating with the Fremen as the House of Atreides, has been completely wiped out by the Harkonnen under the orders of the Imperium. Many elements of the Fremen consider Paul to be the chosen
So
one.
hypermetabolic states and
Growing relationship with Chani and the two.
some disturbance is going on. Okay, so these are the other causes after RV failure: cardiac tamponade, aortic stenosis, atrial stenosis, and hypermetabolic states. These are all the other causes of difficult, physiologically difficult airway. So in these cases, if intubation is needed, you have to go for. Now, this is a new terminology I came across when I was reading this article yesterday. Have you heard of this particular acronym? Oops. Vidya, Risha, Sanjutha, Shobika.
No, sir.
No, sir.
Oh, okay, okay. So there are two patients and pictures shown here. One is marked wrong, one is marked right. What is the difference you see between these two patients? This patient is being ventilated with an ambu bag mask ventilation with an ambu bag, and it is marked red X, means that means the procedure being done is wrong. And the second one is given a green tick, which means it is being done correctly. So the initial response to a patient with airway compromise and decreased level of consciousness is not to keep them supine, but to follow whoops. Oxygen on, pull the mandible forward, sit the patient up. So this is the acronym. O stands for oxygen on. So the patient is being given oxygen with a high flow nasal cannula. Pull the mandible forward. You can see the resuscitator is trying to pull the mandible forward to open up the airway, and they are keeping the patient with the head up tilt. Okay. So in an unconscious patient, when you want to oxygenate the patient, do not do this in this position in a fully supine patient. Rather go for this. So this is called the whoops method. And what do these X-rays show you? I can keep, this is the red line you are seeing. So what do these red lines indicate?
Upper airway obstruction.
Excellent. Upper airway diameter. Very good. X-rays demonstrate that head tilt and chin lift does not impact the upper airway patency. That's what, this is the reason why I think it is like apt that I chose this picture here, because Sanjutha mentioned that you can give head tilt and chin lift, which is a customary way where we are trained to open up the upper airway. And they have proved by taking the X-rays that head tilt and chin lift does not impact the upper airway patency. However, the head and jaw forward position, so just like this, to try to pull the entire jaw forward, that will give a better diameter opening about the airway. Okay, so we were all thinking all these days that only head tilt and chin lift will give a open up the airway. They have proved with an X-ray that it does not increase the diameter. On the contrary, the head and jaw forward position is shown to increase the patency. Hope that was interesting. And so I'll just stop here and we'll go to the next topic. Any questions on this? Any doubts? Or anybody wants to contribute more to this?
No, sir.
Okay, right. Shall we go to the next question then? Who is presenting the next one? Kiranmai?
Sir, I'm present.